Dr. Lin, and also the organizing committee asking me to present our work on head and neck cancer. Beginning, I want to thank my colleagues who are working with me on this project, Dr. Apar Ganti, who's oncologist seeing head and neck cancer patient, Muzaffar, who left this place and was initially involved in this work, and now Sanjeev Chaudhary, who's a postdoc and instructor in the lab. He's working on this project. I want to thank them. Also, before beginning my presentation, I want to disclosure, I'm a one of the co-founder of this company, Sanguine Diagnostic Therapeutics, which is located in DRC 1. Also, like to thank other people whose work is reported in the publication, Dr. Lin, Chilin, and Manish Chan, and other people on animal models. Bill Lydiot was initially, I started work with him, Dr. Jones, a physicist, a pathologist, and a lab manager, Corinne and Kavita Malia. I want to thank them, and also the funding which I've been using for this work. Thank you. So highlight of my work is on radiation therapy, which is very critical for the treatment of head and neck cancer patient. But the efficacy of radiation therapy is reduced because of radioresistance, induction of an alternative pathway, because of radiation causes expansion of cancer stem cell. So what I'm going to be covering today is small molecule inhibitors, which are effective in radiosensitization. I'm going to be covering. I will be covering also, even those are not responding all, so they lead to alternate pathway. Then we use combination of treatment with other inhibitor, which is bringing changes in metabolic rewiring, and combination therapy is very, very effective in treating head and neck cancer in xenograft model as well as in spontaneous model. So a little bit, I heard from my clinical associate colleagues about head and neck cancer, but let me again emphasize, it's a 6th leading cause of worldwide cancer related, and it's increasing 30% and by 2030, and it's highly prevalent. If you see, highly prevalent in South Asia, Australia, and Western Europe. So this is an incidence. This is from one of the Nature Review article. It's high where darker areas, 10 out of 100,000 people are positive with this cancer. This is increasing at the rate it will become very high in number. So this is a paper we published several years ago in JNCI, and we showed how we call head and neck squamous cell carcinoma. This is basically majorly oral cavity cancer, 33%, and then we have some of the other division. Yeah, new cases we are adding, and death rate is not changing over the last so many years. There is a disparity in incidence and survival in African American and white. So white, although the incidence is higher as compared to American in all types of head and neck cancer, but you see the survival is very sad in some of the cancer in African American. So survival rate is very low. Having said this little background before I bring to my option here, these are the genetic landscape available. We know what is happening in this area. Normal mucosa is having a loss of CDK and inactivation occur. Then there's a deletion of 17p region. And also, there are a lot of tumor suppressor genes are lost. And there is a gain of EGFR expression. So there are several factors which are associated with this progression of the disease. HPV positive as well as HPV negative, there are factors also which are associated with the progression of the disease. Because of lack of time, I don't want to go to the etiology of the cancer, but overall what we see is initiation of oral cavity cancer is occurring because of the activation of some of the gene, particularly mucin MUC1 and EGFR overexpression, and some of the major losses of tumor suppressor gene occur. So if we take the complete landscape of oncogene and anti-oncogene, what we see here, very high level of EGFR mutation overexpression. 90% of the patient, I'm not going to all the gene, but I'm just going to focus on EGFR. EGFR, there's amplification, overexpression, there is a deletion, mutation in EGFR occur both in HPV negative as well as HPV positive patient. and HP 90% patient have EGFR overexpression. And EGFR overexpression is associated with very poor survival of the patient also. How we are treating, I heard from people here, but I didn't see about more for treatment. In general, about immunotherapy, I did hear. Radiotherapy is very common form of treatment for head and neck cancer. Radiotherapy and surgery are given at early stage also. Then we give systemic therapy and we give targeted therapy on anti-EGFR, antibody or small molecule. These are the common way of treatment. So as is a focus in radiotherapy, I'm going to be giving you some on radiotherapy. This paper came last year in Oncogene. It's a review article, and they are saying, this is from University of Michigan, they are saying radio resistance in head and neck cancer. There are dire need for new radiosensitizer because become very fast radio resistance occur. So radiation surgery is given in the first stage, 1, 2, but then we are given a combination of therapy are given, but it's radio resistant, chemo resistant. Of course, later on, it become very problematic for treating those patients. So why we are seeing radio resistance radiation? We have seen 1/3 of patients develop radio resistance, and because of radio resistance is due to several pathways. EGFR pathway is one of them I'm going to be targeting here. I'll be showing how, and when we treat even EGFR pathway, other pathway get activated. So many people do not respond. Even you put afatinib and radiation, it doesn't treat, they don't respond. So the alternate pathway are getting activated. There's a metabolic rewiring is occurring. So what happened? Radiation causes DNA damage, and basically EGFR pathway repair it. So it's going anti to what is DNA dying. So EGFR get activated by and what is major, which we find, and many other have reported in multiple cancer, we have reported in other cancer also, radiation treatment causes activation of expansion of cancer stem cell. So there's an increase in cancer stem cell, which is leading to more resistance phenotype and other pathway get activated. So I'm going to show you some of the targeting which we are done with EGFR and also combination with radiation. So this is standard we did in this paper published a couple of years ago, where the two established cell line SCC1 and SSC10B, and the bottom two cell lines are immortalized cell line. The upper two cell line, you're seeing both erlotinib and afatinib, how it is treating this various concentration for 24 hours. You are seeing the viability of the cell. Afatinib shows more efficacy for survival of the cells in both cell line, and whereas in normal immortalized cell, there's a little efficacy is there, but not that as compared to in cancer cell line. And this you can see at a molecular level here, both at 0 time to 48 hours. This is a total EGFR changing in both the cell line. Here you're seeing activated EGFR got inhibited by afatinib. So this is more efficacy. I'm showing you afatinib in paper has many other inhibitor also. Afatinib is a pan inhibitor which inhibits all EGFR family, particularly EGFR 1 and 2, very potent inhibitor for and 2 micromolar concentration. You're seeing a complete inhibition of activation of EGFR phospho, and this is irreversible inhibition. Erlotinib does reversible inhibition, but this causes irreversible inhibition. EGFR, HER2, and other EGFR family member get inhibited. Even phospho AKT get inhibited with EGFR pathway. And ERK pathway get inhibited and other pathways. So it is leading to inhibition of phosphorylation with an decrease in cell growth. When we try to combine with the radiation, so this is the same two cell line. Here is the top line is radiation treatment. You're seeing radiation is causing decrease in surviving fraction. But if we add afatinib, we're talking about 1/4 of the concentration which I showed you earlier. It was 0.5 micromolar, and that was 2 micromolar. You're seeing a surviving fraction decreased so much in both cell line. And when we did look for DNA focus, we found DNA damage foci in control. Afatinib is causing, this is like control afatinib 2 micro radiation. And when you go for this is radiation and afatinib together. So you're seeing time dependent. You see control, and this is we counted them. You're seeing radiation causes DNA damage foci, but you add afatinib on that, there is a more cumulative effect of here for where afatinib alone does not cause any changes of radiation causes, whereas combination is more in both cell line control and afatinib you don't see, but radiation causes, and combination of radiation and afatinib causes more DNA damage. So DNA damage is occurring, and DNA damage is at increased because the repair get inhibited. So I'll show you some mechanism more. So this is a cell cycle showing what is happening by when we combine radiation, afatinib with radiation. So this is untreated cell, afatinib, radiation, and combination in both cell line, and there is a quantitation. So both combination treatment leading the cell to getting cell arrested at G1 phase. You're seeing all are getting arrested at G1 phase. So basically, it's not causing apoptosis of the cell, neither radiation nor afatinib, but it is causing a DNA cell cycle arrest. When we look back molecular level of what is happening to the DNA damage molecules, so seen both the cell line here, if you think at afatinib at 2 concentration and radiation here at 8 Gray. So 8 Gray treatment for 24-hour causing activation of EGFR. So EGFR rather getting inhibited, it is getting activated. And same time, we are seeing activation of a survival pathway with AKT. We are seeing getting increase. And again, you are seeing ATM get, so there's a DNA damage response where ATM pathway and BRCA1, they are getting activated with radiation treatment. But the moment you add along with that, or we add pre-treatment with afatinib, all these get inhibited. So overall, combination of this treatment is preventing the DNA repair and also inhibiting increased proliferation of the cell. So this is again a colony forming assay showing here what is happening to cancer stem cell. As I mentioned from beginning, radiation causes expansion of cancer stem cell. So this is just a marker for cancer stem cell when we treat with radiation or afatinib. Afatinib treatment itself causes here, afatinib treatment causes here, you're seeing here, decrease both at both cell line, afatinib causes decrease in cancer stem cell marker. And when we look here at the bottom here, sphere forming acid, and you are seeing here 0.5 micromolar by itself causes, but when you combine with radiation together, there's almost combination between both cell, decrease in tumor sphere formation acid. And when we do cancer stem cell, with normal cancer stem cells are isolated by site population. Here you're seeing a change in the cancer stem cell population as you treat with afatinib. So I'm not going to go detail, but I will show you here the quantitation. Control, you see site population this much afatinib. This is a site population which is more or less represented as a cancer stem cell. Here in numbers are written here. Afatinib causes decrease in cancer stem cell. But we give radiation treatment is causing expansion of cancer stem cell, and cancer stem cell is responsible for relapse or drug and resistance with other chemo also. And combination decreases both. And this in colony forming also, again, afatinib decreases, radiation increases rather, and a combination decreases further. So combination of this in vitro both shows all effect on mechanistically also. Then we try to see how this works in vivo. Vitro is fine. Then we grew these cells in nude mice, and then we treated with the radiation, afatinib, and combination of this. So you can see control here, tumor growth, and then here you are seeing here radiation does very little effect in radiation when you are letting it grow. But when you do afatinib, there's a decrease. But when you do combination of radiation, there is a very much inhibition, and this is a quantitation, and this is a representative tumor. So combination decrease tumor growth. And when we look for marker in those tumor which are left over, this is a Chinese staining. There is a phospho-EGFR. Phospho-EGFR got inhibited. with the treatment with afatinib, radiation causes increase in again EGFR, where combination abolished decreased it, and again cancer stem cell and DNA foci also similarly are decreased with the combination treatment. So overall summary of this section is that ionizing radiation causes, when you give treatment, radiation therapy causes expansion of cancer stem cell. In heterogeneous, when we give ionizing radiation and afatinib together, there is a tumor regression, which I showed in animal model. So this is happening. Afatinib is working directly with EGFR inhibition as well as activation of HER2 with EGFR heterodimer. This afatinib causing inhibition of SRC pathway, leading to decrease in the motility of the cell. Same time, DNA damage is DNA damage when it activates ATM-ATL pathway, DNA repair pathway, it preventing DNA double-stranded breaks to repair back and causing mitotic catastrophe. So overall, it's short. Combination is very effective, but we see patients who don't respond. And we saw in our animal model also, some of the animal did not respond. Some of the xenografts were not responsive. So we did look for staining of those, and then we saw responder was a decrease in cyclin D1, CDK4, CDK6, and phospho-EGFR, whereas non-responders did not see any change. So this is a paper just recently came in 21. And then we tried to look back, what are the reasons non-responders are not responding combination radiation and afatinib? So we did a lot of called gene enrichment analysis, and then we did find the pathway which are activated were the other gene which were not changed, cyclin D1, CDK4, and CDK6. They were these were the pathway got enriched. And there is a drug available for this one. And we try to see inhibitor for the CDK4 and CDK6. I'm going to show you the data combining together. So what is happening? Patient with this which do not respond, or that animal which did not respond, and there was activation of this RB binds with E2F. And there's a drug which is called palbociclib. This drug PLB, this inhibits this, and then this leads to here you can see here. This drug, when we treat it, RB got phosphorylated, RB got down. And this RB got, when it got free, it is causing a DNA arrest, is called cell cycle arrest. And here you're seeing, when this drug alone, it was not effective. When we give this drug alone, this is causing activation of EGFR. So the total EGFR is same, but here you're seeing how much it's EGFR getting activated. And other pathway like cyclin D1, cyclin E1, CDK4, and CDK were activated. So when we combined together, combination was very effective in terms of CDK4 inhibitor with EGFR inhibitor overcome the activation of alternative pathway. Because the time is short, I'm going to go a little faster on this one. So you're seeing it, I'll show you the combination was very effective as compared to both the drug alone, and mechanistically it is going through inhibition of those pathways. So there was a metabolic rewiring occur. Because of time, I cannot give you all, but the paper is published. So in metabolic rewiring, what is happening is there is a decrease in glycolysis and TCA cycle intermediate with combination treatment, and which is leading to a decrease in cell and leading to the cell going towards more senescence. And this is again showing you how the senescence are done by beta-gal staining. Here you are seeing control. And when we add here, you add a PLB, so causing more beta-gal staining, causing senescence in cell. When afatinib does combination, is causing extreme senescence in both the cell line. And this senescence is associated with now decrease. There's no apoptosis with combination, is causing senescence. Cell is a permanent senescence, is causing, that's why tumor is not growing. And here, this is because of the we are changing in the mitochondrial flux also. We did in vivo experiment also, where we are seeing combination of afatinib with the PALB is affecting, we are seeing here tumor growth in 21 days. This is tumor weight, this is tumor volume. And then we did look back in staining of phospho-EGFR, and these all molecules, they decreased in combination. And not only we did in xenograph, we went back and did this study in spontaneous model, and this may be 1 or 2 slides left. I will take 1 more minute. So we had generated a spontaneous model for an head and neck cancer, in which with the tumors that come in the tongue area. So this we have inducible keratin 14 inducible, 3 inducible with the activated KRAS and P53 deletion. So we developed this tumor. They developed tumor in 3 weeks, and we tried to treat this, and then we saw the treatment has delayed their tumor growth, and we found in the staining also in the tumor was decreased on all this marker what I mentioned. So overall conclusion, working model is that if we combine CDK4/6 cyclin D1 and EGFR is induced in radio-resistant xenograph, which I showed animal model, suggesting the activation of alternative pathway. Targeting both this pathway causes cytostatic effect, decreased metabolism, cellular senescence, and reduced delayed tumor growth. So this is happening to this mechanistically, this pathway. What we want to do now in future is combination therapy using both cyclin CDK4/6 inhibitor and afatinib and radiation together in preclinical model, and also want to do clinical trial. All these 3 are approved by FDA-approved drugs. Overall, I want to thank you all for listening my talk. Sorry, I finished in 20 minutes. Thank you.
Thank you very much, Dr. Batra. Now, session is open to questions. So please submit your questions through a Q&A. So I got quite a few questions, actually. I will actually ask each individual presenter. Unfortunately, Dr. Bell has to catch her flight, so she will not be able to participate in this panel discussion. So I think one of the questions, just basically to everybody. So when we are when we are approaching, cancer patients through this multidisciplinary approach. So the question is how we communicate with with each other, how we could clearly define what is what is our role within this multidisciplinary team. And I can answer the first part. I asked Carol actually to jump in, because I think the speech pathology is one for a long time we overlooked, and I think we're really paying more attention now to that. What Carol to add later, but I think one thing I want to say though, as all my malignancies, we approach that through multidisciplinary approach.